Dear students, now we start the questions of the theme clinical pharmacology of drugs affecting the secretory functions of the digestive tract. Lecture plan. The main pathological of the gastrointestinal tract, pathological changes in the stomach, drug used in acid peptic disease. What is it? Agent that reduce the intragastric acidity, antacids, H2 receptors antagonists, proton pump inhibitors, prostaglandin analogs, bismuth compounds, and another drugs from this group. We must remember the digestive disorders, that is the very many disease, very many diagnoses, that is the problems of the esophagus, of stomach, pancreas, duodenum, the intestinal tract, bile tract, liver. But today we will provide the accent to the problems of the stomach. We must remember about the acute and chronic gastritis. We must remember about the gastric atrophy. Usually that is the results of the chronic Helicobacter positive gastritis without the very intensive clinical symptoms. During the long time, the patient has the persistent infections, Helicobacter pylori, in the mucus of the stomach, and per some period the patients had the decreasing of the acidity in the stomach and progressions this gastric atrophy to the cancer of the stomach. Gastric cancer, duodenal ulcer, practically we cannot find the cancer of the duodenal. That is interesting fact. We don't know why, but practically cancer is even impossible in this part of the gastrointestinal tract. Gastric ulcer, mild lymphoma, that is the results of the absolutely abnormal answer to the chronic Helicobacter pylori infection. Peptic ulcer disease, that is the complications of the chronic Helicobacter or non-steroid anti-inflammatory drugs affect to the surface of the stomach. Drugs used in acid peptic disease. Acid peptic disease include gastroesophageal reflux, peptic ulcer, and stress-related mucosal injury. In all these conditions, mucosal erosions or ulcerations arise when the caustic effect of aggressive factors, acid, pepsin, bile, overhaul the defensive factors of the gastrointestinal mucosa. Over 90% of peptic ulcer are caused by infections with the bacterium Helicobacter pylori or by use of non-steroid anti-inflammatory drugs. Drugs used in the treatments of the acidic peptic disorders may be divided in two classes: agents that reduce intragastric acidity and agents that promote mucosal defense. What agents that reduce intragastric acidity? That is for the first, antacids. Antacids have been used for centuries in the treatments of the patients with a dyspepsia and acid peptic disorders. They were the mainstay of treatments for acid peptic disorders until the advent of H2 receptors antagonist and proton inhibitor pump. They continue to be used commonly the patients, but non-prescription remedies for the treatments of intermittence, heartburn, and dyspepsia. And for the doctors, I'm a doctor, there is the problems for us and for our patients, because without the control, these drugs sometimes after the long time using of these drugs provide the side effects. And later we will discuss about these serious problems for our patients. Antacids are a weak base. They react with the gastric hydrochloric acid, is formed as salt and water. Their principal mechanism of actions is reductions of intragastric acidity. After the meal, approximately the 45 after the house of the hydrochloric acid is secreted. A single dose of the 158 microequivalent of the antacids given 1 hour after a meal effectively neutralized gastric acid for up to 2 hours. However, the acid neutralization capacity among different the proprietary formulations of antacids is highly variable, depending on the rate of dissolutions, tablet versus liquid, water solubility, rate of reactions with acid, and rate of the gastric emptying. Classic variant of the anticides, Alka-Seltzers, Tums. The patients very like to use these drugs for the stopping of the heartburn, of the increasing of the acidity, decreasing of the pH in the stomach. Sodium bicarbonate, that is the baking soda, Alka-Seltzer, reacts rapidly with the hydrochloric acid to produce carbon dioxide and sodium chloride. Calcium carbonate, TAM, is less soluble and reacts more slowly than sodium bicarbonate with H-chlor to form carbon dioxide and calcium chloride. Like sodium bicarbonate, calcium carbonate may cause built-in of metabolic alkalosis. Calcium carbonate is used for a number of the indications apart from its anticides properties. Excessive doses of either sodium bicarbonate or calcium carbonate with the calcium-containing dairy products can lead to the hypercalcemia, renal insufficiency, and the metabolic alkalosis, milk alkali syndrome. Sometimes we saw the stones in the kidneys and stones in the gallbladder, and we don't understand why. Usually that is a result of the chronic hypercalcemia. For the first, we must to find the hyperparathyroidism, high-level concentrations of the parathyroid, because the parathyroid provide the increasing of the concentrations of the calcium ionum and provide these results. Why? Because the organism wants to move this calcium from the organism per bile way and renal way. But we saw absolutely normal results. In these situations, we ask, maybe do you use the long time without the doctor's control these drugs for the stopping of your heartburn? Yes, doctors, really, I have the serious problems, but these drugs has the very excellent effect to my heartburn, immediately stopping. But the side effects of these situations are hypercalcemia, next step, the renal insufficiency and metabolic alkalosis. We must repeat these informations to our patients because this uncontrolled using of these drugs provide the renal and hypercalcemia side effects. Next group, Maalox, Milanta, maybe Gelusil. What is it? Formulation containing magnesium hydroxide of aluminium hydroxide reacts slowly with the H-chlor to form magnesium chloride and aluminium chloride and water. Because no gas is generated, built-in does not occur. Both magnesium and aluminium are absorbed and excreted by the kidneys. Hence, the patients with the renal insufficiency should not take this agent long-term, because this treatment of stomach practically kill the kidneys of our patient. All anticides may affect the absorptions of the medications by binding the drugs, reductions of absorption, or by increasing intragastric pH, so that the drug dissolutions of solubility, especially weakly basic or acidic drugs, is alterated. Therefore, anticides should be given within the 2 hours of doses of the tetracycline, fluoroquinolones, intraconazole, and iron. You must remember in your CROC 2 and practically in questions on the government examinations, you will have the question, the patient's long time use the anticide therapy, and after the start of the using of the tetracycline, for example, doxycycline, the patient has not any effect of treatments of these antibiotics. Why? Because this is the classic variant of interactions of the drugs, pharmacokinetic antagonism. Why? Because the high level pH, low level of the acidity, chemical effect of the anticide to the tetracycline provide the stopping of the absorptions of these antibiotics to the blood, and absolutely zero effect of these antibacterial treatments. These results we saw when the doctors used the tetracycline, fluoroquinolones, intraconazole, and iron treatment. Next group, A2 receptors antagonists. 4 A2 antagonists are in the clinical use: cimetidine, ranitidine, famotidine, and nizatidine. Practically, this is the picture of these drugs: ranitidine, cimetidine, nizatidine, and famotidine. All 4 agents are rapidly absorbed from their intestine. cimetidine, ranitidine, and famotidine undergo first-pass hepatic metabolism, resulting in bioavailability of approximately 50%. Nizatidine has little first-pass metabolism. That's why maybe these drugs has the more high concentrations in the blood. The serum half-life of the four agent range from the 1.1 to 4 hours. However, durations of actions depends on the dose given. A2 antagonists are cleared by combinations of hepatic metabolism, glomerular filtrations, and renal tubular secretion. Dose reductions is required in patients with the moderate to the severe renal insufficiency. In the elderly, there is a decline up to the 50% in drug clearance, as well as significant reductions in volume of distribution. Classic variant in the real clinical practice: cimetidine, ranitidine, nizatidine, famotidine. That is the scheme of using of these drugs: cimetidine, ranitidine, nizatidine, famotidine. Potency: the high, that is the famotidine. Dose from the 480 milligram in cimetidine, ranitidine, that is 150 milligram, nizatidine 150 milligram, famotidine 20 milligram. Pharmacodynamics: the H2 antagonist exhibit competitive inhibitions at the parietal cells A2 receptors and suppressed basal and meal-stimulated acid secretions in the linear, dose-dependent manner. They are highly selective and don't effective H1 or 3H3 receptors. The volume of gastric secretions and the concentrations of the pepsin are also reduced. A2 antagonists reduce acid secretion stimulated by histamine as well as by gastrin and cholinomimetic agent through two mechanisms. First, histamine released from the cells by gastrin and vagal stimulations is blocked from binding to the parietal cells A2 receptors. Second, direct stimulations of the parietal cells by gastrin or acetylcholine has a diminished effect on acid secretions in the presence of the A2 receptors blockage. The potencies of the 4 A2 receptor agonists were over of the 50-fold range. When given in usual prescriptions dose, however, all inhibits 60–70% of total one-day acid secretion. A2 antagonists are especially effective at inhibits nocturnal acid secretion, but they have the modest impact of the meal stimulations acid secretion. Therefore, nocturnal and the fasting intragastric pH is raised to the 4–5, but the impact of the daytime meal stimulation pH profile is less. The dose available in over-the-counter formulations, the durations of acid inhibitions is 6 to 10 hours. Clinical uses of the A2 receptors antagonist. A2 receptors antagonists continue to be prescribed, but PPI are more commonly prescribed than A2 antagonists for most clinical indications. What indications? That is the gastroesophageal reflux disease. Patients with frequent heartburn or dyspepsia may take either antacids or intermittent A2 antagonists. Because antacids provide rapid acid neutralizations, they afford faster symptoms relief than A2 antagonists. However, the effect of antacids is short-lived, only maybe maximum 2 hours, compared with the A2 antagonist 6 to 10 hours. A2 antagonists may be taken prophylactically before the meal in an effort to reduce the likelihood of heartburn. Frequent heartburn is better treated with the twice-daily A2 antagonist or PPI. In patients with the erosive esophagitis, approximately 50% of patients with the gastroesophageal reflux disease, A2 antagonists afford healing in less than 50% of patients. PPI are preferred because of the superior acid inhibition. Next indications of using of the A2 antagonist. Peptic ulcer disease. PPI have largely replaced the A2 antagonist in the treatments of the acute peptic ulcer disease. Nevertheless, A2 antagonists are still sometimes used. Noctural acid suppressions by A2 antagonists afford effective ulcer healing in most patients with the uncomplicated gastric and duodenal ulcer. Hence, all the agents may be administered only daily at bedtime, resulting in ulcer healing rates more than 80% after the 6-8 weeks of therapy. For patients with the ulcer caused by aspirin or another non-steroid anti-inflammatory drugs, these drugs should be discontinued. If the non-steroid anti-inflammatory drug must be continued for the clinical reason, dispute active ulcerations, and PPI should be given instead of the A2 antagonist to more reliability promote ulcer healing. For patients with acute peptic ulcer caused by Helicobacter pylori, A2 antagonists no longer play a significant therapeutic role. Helicobacter should be treated with a 10 of 14 days course of therapy, including the proton inhibitors pump and 2 of 3 antibiotics. Next indications. Non-ulcer dyspepsia. A2 antagonists are commonly used as an over-the-counter agent and a prescription agent for the treatments of intermittent dyspepsia not caused to the peptic ulcer. However, benefit compared to the placebo has never been convincingly demonstrated. Prevention of bleeding from the stress-related gastritis. Clinically important bleeding from the upper gastrointestinal erosions or ulcers occurs in the 1 to 5% of critically ill patients as a result of the impaired mucous defense mechanism caused by poor perfusion. Although most critically ill patients have normal and decreased acid secretions, numerous studies have shown the agent that increase intragastric pH, reduce the incidence of clinically significant bleeding, and should be administered to the patients who are at this risk of gastrointestinal bleeding. However, the optimal agent is uncertain. The patients who are unable to receive internal medications, either intravenous A2 antagonist and proton pump inhibitors may be administered. Continuous infusions of the H2 antagonist are generally preferred to bolus infusions because they achieve more consistent, sustained elevations of intragastric pH. Adverse effect. We must remember, when we prescribe the drugs to all patients, we must understand in our hand we have the weapon. And sometimes these drugs provide them invalidizations or sometimes death of our patient. That's why in any case, we must very intensive study the adverse effect of all drugs what we want to prescribe. A2 antagonists are extremely safe drugs. Adverse effects occur in the less than 3% of patients and include the diarrhea, headache, fatigue, myalgias, and constipations. Some studies suggest that intravenous H2 antagonists may increase the risk of the nosocomial pneumonia in critical ill patients. Mental status changes, sometimes there is the confusions, hallucinations, agitations may occur with the administrations of intravenous H2 antagonists, especially in the patients of the intensive care unit who are the elderly or who have renal or hepatic dysfunctions. These events may be more common with the cimetidine. Mental status changes rarely occur in ambulatory patients. Cimetidine inhibits binding of dihydrotestosterone to androgen receptors, inhibits metabolism of estradiol, and increases serum of the prolactin levels. When used a long time or in high dose, it may cause gynecomastia or impotence in men and galactorrhea in women. These effects are specific to the cimetidine and don't occur with this other A2 antagonist. Sometimes our patients come into our office, doctors, I don't understand, men talk me. I have the gynecomastia, I don't understand why. I have the specializations in endocrinology, clinical immunology, infection disease, but one my specializations is endocrinology. I don't understand why I have the gynecomastia. Why? For the first, we must exclude of the tumor of the brain. Sometimes the adenoma of the hypophysis provocate the increasing of the concentrations of the prolactin and provocate the galactorrhea in men. Absolutely abnormal situation. But for the first, we must ask, maybe did you use the drugs for the treatments of your stomach? Oh, yes, doctors, maybe. What do you like to use for the stopping of your heartburn? Cimetidine. If we will change of these prescriptions, we practically stopping of absolutely non-necessary MRI verifications of problems of the central nervous systems. Although there are no harmful effect of the fetus, A2 antagonists cross the placenta. Therefore, they should be not administered to the pregnant women unless absolutely necessary. The A2 antagonists are secreted into the breast milk and may therefore affect Nor's infant. A2 antagonists may rarely cause blood dyscrasias. Blockage of the cardiac A2 receptors may cause bradycardia, but this is rarely or clinical significant. Rapid intravenous infusion may cause bradycardia and hypotensions through blockage or cardiac A2 receptors, classic clinical symptoms of the collapse. Therefore, intravenous infusions should be given over the 30 minutes, very, very slow. A2 antagonists rarely cause reversible abnormalities in the liver chemistry. Drug interactions. We must remember that cimetidine, especially cimetidine, that is the very aggressive inhibitors of the CYP3A4. We must remember, if we will prescribe together the substrate of the CYP3A4 and inhibitors of the CYP3A4, these interactions provide the stopping of destroying of the substrate, and concentrations of the substrate will be increased. That's why the prescriptions of the cimetidine and these drugs can stopping of the activity of the 4 isoenzymes of the cytochrome oxidase P450, that is the CYP1A2, CYP2C9, CYP2D6, CYP3A4. Maybe you know about these isoenzymes. These drugs can provocate the increase in the concentrations of the another drugs, very many drugs, which patients use now according to the prescriptions of the another doctors. Hence, the half-lives of drugs metabolized by these pathways may be prolonged. Ranitidine means the 4 to 10 times less evidently than the cimetidine cytochrome 450. That's why when the patients use the other drugs, please we recommend don't prescribe the cimetidine. Please prescribe the ranitidine for the treatments of your patients, for the preventions of the increasing of the concentration of the another drugs. Negligible CYP interactions occurs with the nizatidine and famotidine. A2 antagonists compete with the creatinine and certain drugs, procainamide, for example, for renal tubular secretion. All these agents, except famotidine, inhibits gastric first-pass metabolism of ethanol, especially in women. Although the importance of this debate increased by availability of ethanol could lead to increased blood ethanol levels. Next, very big and very popular and very useful for doctors and for patients, the group of the drugs for the decreasing of the acidity in the stomach, that is the proton pump inhibitors. Practically 6 drugs from this group are available for the clinical use: omeprazole, esomeprazole, lansoprazole, dexlansoprazole, rabeprazole, and pantoprazole. These drugs practically we like to use for the treatments of the gastritis, of ulcer, of another disorders in the stomach. Practically, esomeprazole is the S form, sinister isoform of the omeprazole and dexlansoprazole, the ERF isomers of lansoprazole. All are available in oral formulations. Esomeprazole and pantoprazole are also available in the intravenous formulations. Proton pump inhibitors are administered as inactive prodrugs and protect of the acceptable prodrug from the rapid destructions within the gastric lumen. Oral productions are formulated for the delay released as acid resistance enteric coated capsule or tablets. After the passing through the stomach into the alkaline intestinal lumen, the enteric coating dissolves and the prodrug is absorbed. For children or patients with the dysphagia or internal feeding tubes, capsular formulations, but not tablets, may be opened and the microgranules mixed with apple of orange juice or mixed with the soft food. Esomeprazole, omeprazole, and pantoprazole, that is the form esomeprazole, rabeprazole, omeprazole, pantoprazole. Very effective drugs for the treatments of the gastritis and ulcer of the stomach. Lansoprazole is available as a tablets formulations that disintegrate in the mouth, and rabeprazole is available of the formulations that may be sprinkled on food. Omeprazole is also available as a powder formulations, capsule or packed, and contain sodium bicarbonate to protect the naked non-enteric coated drug from acid degradation. There is rapidly undergoes molecular conversions to the active form and the reactive theophilic sulfonamide quotient, which form of the covalent disulfide bond, the kalinatrium ATPase, irreversibly inactivations these enzymes. Immediate release omeprazole has a fast onset of the acid inhibitions that other oral formulations. Although difference of the pharmacokinetic profiles may be affect speed of onset of the durations of acid inhibitions in the first few days of therapy, they are a little clinical importance with the continuing daily administration. Classic drugs from this group: esomeprazole, rabeprazole, omeprazole, pantoprazole. Pharmacodynamics of these drugs is in contrast to the A2 antagonist. The proton inhibitor POMP inhibits both fasting and meal stimulation secretions because they block the final command pathway of the acid secretions, the proton pump. In started doses, proton inhibitor pump inhibit maybe 99%, 98% of 24-hour acid secretions. When administered in equivalent dose, the different agents show little difference in clinical efficiency. In a crossover study on the patients who received long-time therapy with the inhibitor proton pump, the mean 24 hours intragastric pH varied from the 3.3 pantoprazole, esomeprazole, and the mean number of hours the pH was higher than the variant from the 10 pantoprazole and 14 esomeprazole. Clinical uses for the proton pump when we can to prescribe this treatment: gastroesophageal reflux disease. Proton inhibitor pump are the most effective agents for the treatments of erosive reflux disease, esophageal complications of reflux disease, peptic structure of the Barrett esophagus, and extra esophageal manifestations of the reflux disease. What problems of this disease, gastroesophageal reflux disease? In normal, absolutely the H-chlor and pepsin and another part of gastric cannot return to the esophagus, but when the patient has the problems with the sphincter open, allowing the reflux, these acid remedies return to the esophagus, and we understand the surface of the esophagus cannot answer to this aggressive attack, and we can see in very many situations metaplasia of this epithelium of the esophagus and transforming to the cancer in this area of the gastrointestinal tract. Once early dosing provide effective symptoms when we prescribe the inhibitors of the proton pump, and tissue healing in the maybe 90% of the patients, up to the 15% of the patients require twice daily dosing. Gastrointestinal, these reflux problems recur in over 80% of patients with 6 months after the discontinuations of a proton inhibitor pump. For patients with erosive esophagitis and esophageal complications, long-term daily maintenance therapy with a full dose of half dose of the proton inhibitor pump is usually needed. Many patients non-erosive reflux problems may be treated successfully with intermittent course of the proton inhibitor pump of A2 antagonist taken as needed for recurrent symptoms. In current clinical practice, many patients with a symptomatic GERD are treated empirically with the medications without the prior endoscopy, without knowledge of whether the patient has erosive or non-erosive reflux disease. Empiric treatments with the proton inhibitor proton pump provide sustained symptomatic relief in 80% of patients. Compare it with the 60% with the A2 antagonist. Because recent cost reductions, PPI, are used increasingly of the first-time therapy for patients with the symptomatic of this reflux. Due to the recent safety concern, however, initial empiric treatments for the A2 antagonist should be considered. Sustained acid suppressions with a twice-daily inhibitor proton pump for at least 3 months is used to treat esophageal complications or reflux disease, asthma, chronic cough, laryngitis, and non-cardial chest pain. Sometimes these patients come into our office, doctors, maybe I have the infarct of myocardium, I have the very intensive in the retrosternal area, and we ask, do you have the increasing of your pain when you will walk, and maybe run? No, doctors, when I take any things and my flex my body, I have the increasing of the intensity of the pain in this area. Sometimes after the verifications of the absolutely negative non-infarct situations, we prescribe the fibrogastroscopia for the verifications of this reflux esophagitis and start to the treatments with the proton inhibitor pump for and during the short period, this patient has the positive clinical effect. Sometimes the patient has the laryngitis, chronic cough, asthma, and this disease can provoke the symptoms same as the esophagitis. We must to provide the differential diagnosis. When the patient has the Helicobacter pylori positive gastritis or gastritis which induce the non-steroid anti-inflammatory drugs, we must remember of treatments with the proton inhibitors pump. Peptic ulcer disease. These drugs provide a very quick, very intensive effect to our patients. All the pump inhibitors heal more than 90% of your duodenal ulcer with this 4-week and similar percentage to this gastric ulcer within the 8 weeks. A Helicobacter pylori ulcer, and we like to prescribe these treatments. The most effective regime for the Helicobacter pylori eradications, which is the combinations of the proton inhibitor pump with the minimum 2 antibiotics together, sometimes 3 antibiotics if that is the resistance, that is the repeating of the treatments of our patients with the Helicobacter positive gastritis or ulcer. Due to the increase in the treatments failures attributable to the rise in the clarithromycin resistance, quadruple therapy is now recommended as first line treatments for the patients who likely have the clarithromycin resistance due to the prior exposure or to residence in region with the high clarithromycin resistance. 2 400-day treatments regime currently are recommended. Each include PPI twice daily with another bismuth subsalicylate. We must remember when we prescribe the bismuth, the color of the stool of these patients will be changed to black color. And sometimes, and we must talk about these side effects after the use of the bismuth for our patients. Why? Because in this day, the patients in night will see, for example, the changes the color of the stool, black color. Immediately Google will check, maybe that is the melena. I have the bleeding from my ulcer. Maybe I have the serious complications. No, that is the absolutely normally side effects, absolutely non-dangerous side effects after the start of the using of the bismuth. For example, denol. Metronidazole, we can to use for the stopping of the Helicobacter pylori, but we must remember metronidazole very aggressive inhibitors of the CYP3A4, and these drugs provocate the increasing of the concentrations of another drugs, cardiovascular drugs, and another, and we can provocate the hepatotoxic effect of another drugs to our patients. That's why, and metronidazole during the long time using provocate the problems with the blood, the decreasing of the neutrophils, decreasing of the erythrocytes, anemia. That's why we must prescribe very accuracy these antibacterial drugs for our patients. Tetracycline, please, we cannot prescribe these drugs for the children. We cannot prescribe for them pregnant women, and tetracycline can provocate a very serious problem with the teeth, with the liver, and dysbiosis, dysbacteriosis. But if that is the short period, 10 days, not more, we can to prescribe with the control, doctor's control, all given 4 times daily, or amoxicillin, practically amoxicillin, absolutely non-toxic antibiotics, but very dangerous for the patients with the allergic reactions of bronchial asthma and another problems. Clarithromycin, practically very aggressive inhibitors of the CYP3A4, provocate the increase of the concentrations of the other drugs. Metronidazole, all given twice daily. After the completion of the antibiotic therapy, the proton inhibitor proton pump should be continued once daily for a total 6 weeks to ensure complete ulcer healing. Non-steroid associated ulcer, please, for patients with the ulcer caused by aspirin or another non-steroid anti-inflammatory drugs, either I2 antagonist or PPI, provide rapid ulcer healing so long as the non-steroid anti-inflammatory drugs is discontinued. However, continued use of the non-steroid anti-inflammatory impairs ulcer healing. We must remember what mechanism of working of the non-steroid anti-inflammatory drugs, that is the inhibition process of the cyclooxygenase 1 and cyclooxygenase 2. Cyclooxygenase 1, that is the good, positive enzymes. These enzymes protect the mucosa of the stomach. Cyclooxygenase 2, that is the bad enzymes. These enzymes provocate the increasing of the symptoms of the inflammations, increasing of concentrations of the prostaglandin, and that is the pro-inflammatory part. SOC1 and SOC2. When we prescribe non-selective, non-steroid anti-inflammatory drugs, these drugs stopping of the activity SOC1 and SOC2. SOC2 very good with stopping of the process of the pro-inflammatory effect, but SOC1 with stopping of the gastroprotective effect of these enzymes. That's why the side effects after the using of the non-steroid anti-inflammatory drug, gastritis and ulcer. In patients with a non-steroid anti-inflammatory induced ulcer who require continued non-steroid therapy, treatments with the PPI more reliably promotes ulcer healing. Asymptomatic peptic ulcer develop maybe in turn 20% of people taking frequent non-steroid anti-inflammatory drugs, and ulcer-related complications, bleed, perforations, developing 1–2% of person per year. First very dangerous symptoms, that is the black color of the stool, that is the melena, that is the dizziness, that is the cold temperature of the extremities, that is the anemia, tachycardia, that is the symptoms of the bleeding from the ulcer of the stomach. PPI taken once daily are effective in reducing the incidence of the ulcer and ulcer complications in patients taking aspirin or another non-steroid anti-inflammatory drugs. The results of this chronic using, sometimes gastritis, sometimes ulcer, peptic ulcer. Preventions of the rebleeding from the peptic ulcer. In patients with acute gastrointestinal bleeding due to the peptic ulcer, the risk of the rebleeding from the ulcer that have the visible vessels of the adherence, the clot, increase. Usually we prescribe very aggressive PPI treatments for these patients, omeprazole, lansoprazole, Periet, rabeprazole. And the optimal dose of the intravenous, sometimes PPI, needed to achieve and maintain this the level of the near complete acid inhibitions of ANCNOA. However, initial bolus administrations of the esomeprazole or pantoprazole, 80 mg, followed by contrast infusion, is commonly recommended. Non-ulcer dyspepsia. PPI have modest efficiency of the treatments of the non-ulcer dyspepsia, benefiting maybe 10 to 20 more patients than placebo. Dispute their use for these indications. Superiority to A2 antagonist has not been conclusively demonstrated. Prevention of the stress-related mucosal bleeding. The only PPI approved for the indications and on the oral immediate release omeprazole formulations, which is administered by nanogastric tube twice daily on the mucose day, then once daily. Although they're not approved for the indications, other PPI suspensions formulations, esomeprazole, omeprazole, pantoprazole, may also be used. For patients with the nasoenteric tubes, PPI suspensions may be preferred to the intravenous A2 antagonist or PPI because of comparable efficiency, lower cost, and ease of administration. Gastrinoma and another secretory conditions. What is it, gastrinoma? That is the tumors which provide the increasing of the synthesis and secretions of the gastrin, that is the hormone of gastrointestinal tract, and provide the increasing of the acidity in the stomach, provocate the gastritis and ulcer. Patients with the isolated gastrinomas are best treated with the surgical resections, but we must to provide the stopping of the very high level acidity in the stomach for the prophylaxis of the bleeding, penetrations, perforations of this ulcer. Dosage is titrations and reduced basal acid output less to the 510 milliequivalent an hour. Typical dose of the omeprazole 60 or 120 milligram per day. Zollinger-Ellison syndrome. In any case, if you will see the very high level concentrations of the gastrin, we can check according to the laboratory testing this hormone. We must to provide them computer tomography, MRI. We must find of source of this gastrinoma. But before the operations, we must to provide the very aggressive PPI treatments of our patient. Adverse effect general. Although the PPI have been considered by extremely safe, and a number of the recent safety concerns have been raised, as the most drugs should be prescribed at the lowest effective dose, and the risk versus benefits of long-term use carefully are weighted. Diarrhea, headache, and abdominal pain are reported maybe in 5% of patients, although the frequency of these events in only slightly increased compared with the placebo. The mechanism of which kidneys damage much occur has not been determined. Some epidemiological studies have also detected an increased risk of the dementia in long term of the PPI users, although causality is not being established. PPI are not teratogenic in animal models. However, safety during the pregnancy has not been established. Nutrition. Acid is important of the releasing vitamin B12 from food. Amino reductions in oral cyanocobalamin absorptions occur during the proton pump inhibitors, potentially leading to the subnormal B12 level of the prolonged therapy. Acid also promotes absorptions of the food-bound minerals, non-hem iron, insoluble calcium, salt, and magnesium. Classic variant of the pharmacokinetic antagonism. If the patient has the very low level concentrations of the B12, the patient has the classic symptoms of the B12 folioacidic megakaryocytic anemia. Only this anemia has the hyperchromic effect to the erythrocytes, and patients has the very intensive neurological problems, radiculitis, maybe disorders in the extremities, maybe discomfortable in the tongue, and this patient has the black pin in the vision area, dizziness, sometimes disorders in the central nervous systems. That is the real side effects after the progressions of the B12 folioacidic anemia as a result of the long time uncontrolled using of the proton inhibitor pump. Meta-analysis of the cohort and case control studies have detected the modest increase of the risk of the hip fracture in the patients taking long-term PPI. Although the causal relations in unproven, PPI may reduce calcium absorptions and inhibits osteoclast function. Sometimes that is the hypocalcemia. And sometimes the PPI can decrease the absorptions of the iron, decreasing of the level of the ferritin, and problems of the erythropoiesis. Classic symptoms of the hypochromic anemia. Patients who require at long time PPI, especially those with risk factors for the osteoporosis, should be monitoring of the bone density and should be provided calcium supplement. Cases of severe life-threatening of the hypomagnesemia with the secondary hypocalcemia due to the PPI have been reported, possibly due to the decreased intestinal absorption. Respiratory and enteric infection. Gastric acid is an important barrier for the colonizations and infections of the stomach and the intestine from the ingested bacteria. Some studies have reported an increasing risk of the both community-acquired respiratory infections and nosocomial pneumonia among the patients taking PPI. There also is a small increased risk of other enteric infections, Salmonella, Shigella, Escherichia, Campylobacter, which should be considered particularly when traveling in underdeveloped countries. Respiratory and enteric infection side effects. Gastric acid is an important barrier to the colonization. And problems, sometimes these drugs can provocate of the Clostridium difficile, very problems. Why? Because the Clostridium difficile provocate them practically absolutely resistance to the antibacterial treatments, and only one comycin can kill this bacteria. Potential problems are due to the increased serum gastrin. Practically acid suppressions alter normal feedback inhibitions to that median serum gastrin level rise. Other potential problems, such as the decrease in gastric acidity, and that is the provocations of the Helicobacter pylori problems. Chronic inflammations. Concern have been raised. The increased gastric inflammations may accelerate gastric gland atrophy. Routine testing for the Helicobacter pylori is not recommended in patients who require long-term PPI therapy. Long-term PPI therapy is associated with the development of the small being gastric funding gland polyps in a small number of the patients, which may disappear after the stopping the drugs and other uncertain clinical significance. Drug interactions. Decreased gastric acidity may alter absorptions of the drugs for which intragastric acidity affect drug bioavailability, ketoconazole, intraconazole, digoxin, atanozivir. All PPI are metabolized by hepatic P450 cytochromes, including the CYP2C19 and CYP3A4. Because of the short half-lives of PPI, clinically significant drugs interactions are rare. Omeprazole may inhibit the metabolism of the clopidogrel, warfarin, diazepam, and phenytoin. Esomeprazole also may decrease metabolism of the diazepam. Lansoprazole may enhance clearance of the theophylline. If that is the concentrations of the diazepam will be increased, we see the depressions of the central nervous systems. If the theophylline will be increased, these drugs can provocate of the hypotonia, collapse, and death our patients. Rabeprazole and pantoprazole have a significant drugs interactions. The FDA has issued of the warning about the potential important adverse interactions between the clopidogrel and PPI. What symptoms of the increasing of the concentrations of the clopidogrel? Clopidogrel, for the first, that is the hemorrhagic syndromes into the mucus, for the first in the throat, yes, that is the hemorrhagic disorders in the gums. And next step, which is the skin, and maybe first early symptoms of the progressions of the effectiveness of clopidogrel, that is the hematuria. We must ask to our patients during the prescriptions together clopidogrel with the PPI, do you have the changes of the color of your urine? If the patient has the red color of the urine, a hematuria, that is the very first dangerous symptoms of the hypocoagulations of our patients. Clopidogrel is a production that required activations by the hepatic CYP219 is enzymes which also involved to varying degrees in the metabolism of the PPI, especially omeprazole, esomeprazole, lansoprazole, dexlansoprazole. Thus, the PPI could reduce clopidogrel activations in some patients. Several large retrospective studies have reported an increase in incidence of the serious cardiovascular events. When PPI are prescribed to the patients taking clopidogrel agent with the minimal inhibitions, pantoprazole or rabeprazole may be preferred. Prostaglandin analogs. Practically, the human gastrointestinal mucosa synthesis, for example, misoprostol, mifepristone, that is the misoprostol effective part of these drugs. That is the prostaglandin analogs. The serum half-time less than 30 minutes. Hence, it must be administered 3-4 times daily. It is excreted in the urine. However, those reductions is not needed in patients with the renal insufficiency. Misoprostol has both acid inhibitory and mucosal protections propriety. Properties. It is believed to stimulate mucus and bicarbonate secretions and enhance mucous blood flow. Misoprostol can reduce the incidence of the non-steroid anti-inflammatory drugs-induced ulcer to less than 3% and the incidence to ulcer complications by 30%. It is approved for preventions of NSAID inductors, ulcers, and high-risk patients. However, misoprostol has never achieved widespread use owing to its high adverse effect profile and need for multiple daily dosing. Misoprostol, mifepristone. Bismuth compounds. Two bismuth compounds are available: bismuth subsalicylate and non-prescription formulations contain bismuth and salicylate and bismuth subcitrate potassium. In the US, bismuth subcitrate is available only as a combinations prescriptions products that also contain metronidazole and tetracycline for the treatments of the Helicobacter pylori. Bismuth salicylate undergoes rapid dissociations with the stomach, and low absorptions of the salicylate. Over 99% of bismuth appear the stool. That's why if the patient has the cholestatic disorder, stopping, decreasing of the moving of the drugs per bile tracts, we cannot prescribe this drug. The precise mechanism of the actions of the bismuth unknown. Bismuth causes ulcer and the erosion, creating all the protective layers against acid and pepsin. It may also stimulate prostaglandin mucus and bicarbonate secretions. Bismuth salicylate reduces the stool frequency and liquidity on the acute infections diarrhea due to the salicylate inhibitions of intestinal prostaglandins and chloride secretions. Bismuth has direct antimicrobial effect and bind enterotoxin, accounting of the benefits of preventions and treating travelers' diarrhea. Bismuth compounds are direct antimicrobial activity against the Helicobacter pylori. Bismuth subsalicylate, 262 milligram, or peptide bismuth, very popular drugs for the treatments of the Helicobacter pylori, for the treatments nausea, heartburn, indigestions, upset stomach, diarrhea, as antibacterial drugs. Clinical use, when we like to prescribe these drugs, despite the lack of the comparative trials, non-prescriptions bismuth compounds, peptibismuth, calpesite, are widely used. Their patients for the non-specific treatments of dyspepsia and acute diarrhea. Bismuth subsalicylate also is used for the prevention of the travelers' diarrhea. Bismuth compounds are used in 4 drugs regime for the eradications of the Helicobacter pylori. One regime consists of the PPI twice daily, combined with the bismuth salicylate, tetracycline, metronidazole, first for 4 times daily for the 10 or 14 days. Another regime consists of the PPI combinations together with the bismuth subcitrate, metronidazole, tetracycline, take 4 times during the 10 to 14 days. Calpesites, practically that is the calpesites max we can use for the treatments of our patient. Adverse effect. All bismuth formulations has excellent safety profiles. Bismuth causes harmless breaking of the stool, which may by causing past gastrointestinal bleeding. Prolonged using of some bismuth compounds may rarely lead to the bismuth toxicity, resulting in encephalopathy, ataxia, headache, confusion, seizures. However, such that toxicity is not reported with the bismuth subsalicylate or bismuth citrate. High dosage of the bismuth subsalicylate may lead to the salicylate toxicity. Thank you for your attention. And if you will have any questions, welcome, you can ask.